Hi everyone. I'm very happy to be here. It's a bit awkward to not see my audience, but thank you to each one of you who's behind the screen because it makes me feel less alone, I guess. So what I chose to do today is to share my experience as a story. So I'm proposing that I tell the story. It's not very long. It's probably like 10, 15 minutes max. And then we can open up the conversation, if that's okay with you. So I'm a physician. I live in Paris, France, and I'm an ER pediatrician, which means that I treat kids in the emergency department. Sometimes we save their lives, but many times we see runny nose, blisters, and bruises. So when the COVID-19 epidemic started back in January, we also it was some sort of a flu. All we had were China's number, and we had no idea that they were totally flooded. They were reporting at the time about 80,000 cases and about 3,000 to 4,000 deaths. That's a mortality rate of about 3.9%, which we thought was very much overestimated because that number did not take into account the many cases of asymptomatic people. Then the numbers of infection and deaths outside of China started to skyrocket. And we realized that it was not just a flu, it was a tsunami, and it was going to be a catastrophe. We saw it hit Italy first. We were hearing that they were asking ophthalmologists to learn how to use a ventilator. We were hearing that healthcare professionals were dying and that the healthcare system was just not holding up. That's when it became really scary. And we were wondering what was in store for us. So because at that time, with what we knew, we saw that children were very rarely affected by serious forms of the disease. Our hospital started to fully reorganize to welcome adults. In France, we were far from having enough ICU beds, and we had to open new beds as fast as possible anywhere and everywhere. So what we did is we stopped all non-urgent activities and we postponed every consultation, surgery, and exam we could. We moved our pediatric ICU unit to transform it in a 20 adult ICU beds. So an ICU is an intensive care unit. It's where patient can be sedated and artificially breathe through a ventilator while being intubated. So we had that ICU adult unit, and we also transformed our ear, nose, and throat department in a step-down unit of 14 beds. So step-down units are typically for patients who are getting out of the ICU, but they're still very unstable on a medical level. And it can also be used for pre-ICU, for example, for patients who require oxygen, but they don't need yet to be artificially ventilated. So as for me, I was appointed to share my time between my usual job at the ER for kids and in that new step-down unit. And I can tell you that I did not sleep well for the few nights before taking on this new job. I mean, I did learn how to treat adults in my studies, and I did work for sometimes with adults at the beginning of my career, but this is not my daily job. So what I did is I tried my best to read everything I could about COVID-19. I did online courses, MOOCs, which had been made available by my hospital. I downloaded all the healthcare adult smartphone apps that I could find about medical scores and tips and tricks. But still, it was a very difficult transition. And my first day was a nightmare. So we were welcoming both adults that were getting out of the ICU, but we were also welcoming pregnant women who were too unstable to stay in our hospital maternity. And we had one kid who had just underwent an operation for a peritonitis and who happened to be COVID positive. And it happened that in the pediatric surgery departments, they were not equipped to receive COVID positive patients. So I am used to making the diagnosis of peritonitis, but I am not used to care for it after the operation. I'm used to treating babies. I'm not used to treating their moms or their grandparents. And so in 24 hours, it's like I had to do this huge brain upgrade from retrieving all the knowledge that was deep down somewhere in me to acquiring a bunch of new informations. It's like, it felt like going from the iPhone 3 to the iPhone 11 or something. But the craziest in all of that was that we were treating a disease we did not even understand. Every day we were learning that like this new skin symptom had been reported or that neurological effect had been noticed. And we were analyzing chest CT scans that I had never seen before. And we were like, wow, like how can those people even be breathing? I was so shocked by how smashed the patients were. Before you actually see it, I mean, you hear from it, right? You hear that like sometimes it's a runny nose or it's like a big flu for 10 days. You know that some people are dying of it, but it seems quite far, you know, abstract. Well, on that first day, it became very real. It felt like a bulldozer had rolled over those people. They were out of breath all the time. They were talking was becoming this huge effort, and they looked like zombies. And then right when you would think that they were doing better, in just a few hours, they would just worsen up and we had to resend them to the critical care unit. And then there was this big deal about the chloroquine. But the few studies we had showed no scientific evidence of improving the disease. So our patients were on trial for different drugs, and chloroquine was part of it, of course. But in our department, on a small scale, we saw more adverse effects from those drugs than real improvements. It seemed that only time and oxygen seemed to heal those patients once they had managed to get out of the ICU and after they had passed the first 2 to 3 weeks after the first symptoms. And then I remember we had so many discussions about, you know, how to treat those patients, and we never had a final answer. So do we give this drug knowing that it has not shown any medical evidence with the risk of harming the patient with adverse effects, or should we not? What if the patient dies and the family sues us for not trying the drug? But what if the patient dies from its adverse effects and the family sues us for giving him a medicine that was not considered appropriate at the time? What's the answer? And then at the same time as everything was happening, everybody started to glorify the doctors and the nurses. In France, people clap at their window to thank us every night at 8 p.m. Every single night, still now. And it's very comforting and we really appreciate. And I'm sure you've also seen all those cartoons where we have superheroes like Batman and Spider-Man, and they're bowing down, you know, in front of healthcare professionals. And it makes us feel good, but it also makes us feel, you know, funny and a bit awkward because we try our best. I mean, that I promise, we give everything, but we're also out of our usual competence scope. To me, it's like we're sailing like in a thick fog, you know, and we make mistakes and we learn on the go. And some of us have to make hard choices. So I'm not in a critical care unit. I'm not in one of those ICU, but I have many colleagues who are, and they've been telling me that they've been facing with having to decide so many times who might live and who won't. You know, when you know that their ICU unit is almost full, and they know they will be asked to take on new patient every few hours or so, they know that if they accept that 70-year-old grandma, then they're saying no to the next 55-year-old dad. It's horrible. And I don't think that it would make anyone feel like a superhero to take one of those decisions. And also, I mean, you see Spider-Man and Batman, they have like capes and like super outfits. We were lacking everything. Medicines, medical equipment, rightly trained physicians and nurses, personal protection equipment, which we call PPE. And to me, it's kind of like, you know, you're sent to wars, but you're wearing like shorts and flip-flops. All the masks and hydroalcoholic gels that you can usually find in, you know, regular consultation rooms when you go to the hospital, it was all stolen within the first week of the epidemic. So we had to reuse everything to be minimalist to the point where, to be honest, we were just blatantly exposing ourselves. Luckily, after a few weeks, we've had massive help from the general public and the industries. 3D makers made a 3D printed face shields, Chanel donated like a whole bunch of disposable gowns, like, yes, like Chanel, you know, the fancy fashion brand. And L'Oreal made us fancy, you know, hydroalcoholic gels. And it did help. And like, you know, thank you, we felt the love. But as fancy as it got, I mean, the situation was still quite precarious. And I think that for the first time in my life, I felt that I was putting myself in danger for treating other people. And I mean, it wasn't about my own life that mattered. It was the life of the people I live with. My husband is 43 years old. And you know, there are men who are 43 years old in ICUs. I have a 2.5-year-old daughter. So long story short, my husband was in the US when the border started to close down. And then in France, the daycare closed down and I had to work. So I had to let my daughter go with my parents far out in the French countryside. And I haven't seen her since March 15th. And her hair and legs are growing way too fast over FaceTime. And I have that nurse friend. She lives with her mom. And every day when she comes back from work, because she's exposed, she puts her own mother life at risk. And her mother, that could be that grandma of 70 years old that I told you about earlier, is just like, you know, wrong place, wrong timing. But then again, like, how can I complain when I look at the pain that I was seeing out there? In the unit, we had that mother who got separated from her baby at birth because she was infected. When we got her right out of the ICU, she was still very much out. But as the days went by and she got better, we saw her pain increase by the second. And here it's a happy ending. She got to get out and hold her baby after 19 long days. And she sent us pictures and we were all so moved by it. But for some people, it's not a happy ending. Dying patients are being isolated from their families. Visits are not allowed in ICUs. And there's the pain of the families, there's the fear and the sadness of not being able to properly having a funeral for your relatives and friends. So all of this is hard, but at the same time, I could not have pictured myself anywhere else. And our step down unit closed down last Thursday. It's good news. I mean, it means we've reached the peak and the wave is going down. But somehow we felt guilty to feel sad to leave the unit, because for 1 month, our team bonded so much, sailing through the dark, you know, holding on tight to each other, and we cry and we laugh together. And every day we took time, you know, to look at all those funny jokes that you can find on the internet. And maybe also we got probably a bit addicted to that adrenaline. So now we are preparing for 2 waves. The first one is a second wave of COVID patient after, you know, the confinement ends. And the other wave is a wave of patients who need to be treated, but have been put on hold for 2 months. Those are a ticking bomb and it's gonna overflow our system sooner or later. I haven't talked about the situation in the pediatric ER while all of that was going on, but it was dead calm. As I said, the COVID-19 is not serious in children. And with the confinement and the fear, people just stopped coming in. So in a way, it showed that many ER consultations are quite useless, right? The runny nose, like the bruises and mosquito bites. But we also saw that the fear was blinding parents when their kids really needed care. The kids who did come in were much more serious than usual. We saw broken bones that had been broken for like 3 days before they arrived. We saw critical peritonitis when usually kids arrive, you know, they're at the first stage of appendicitis. So the fear is a positive driver for social distancing, but it's also contributing to patients getting more serious and not receiving the care that they should. So yeah, I think that for the next few months or probably years, it's going to be a lot of work for us. But I'm telling myself that I have a job security, and for a long, long time. I mean, I currently belong to a group of people with the best job security in the world, when so many people do not have the same security. I remember, like, when I was at the hospital, we had people baking for us, you know, restaurant delivering super nice food and Easter chocolate eggs. for all the staff. And at the same time, I mean, I have friends who lost their job, and they don't even know how they're going to pay the next rent. So I think today that I'm really worried about how we will bounce back from that crisis as a society. I mean, still now, thousands of people are likely going to die from the coronavirus, sadly. But how many more may die from losing their jobs and paychecks? To me, the consequences are so far-reaching. And I feel that we have so many questions now with so little answers. So to finish my story, I will say that, like, through all of that, I still saw a glimmer of hope in the general public. I saw everyone calling and trying to find out how to help. I saw everyone becoming more caring. I saw everyone being a little bit less individualistic and a little bit more altruistic. So I think it's a good time also to step back and recenter our society around what truly matters. With good health, there is life. With a healthy planet, there is a home. With kindness and love, there is happiness. So now it's up to us to pick where we stand. And that's the end of my story. And now we can have a conversation. Thank you.
Wow, that was amazing. That was touching, and I'm sure if we had a clap feature here, my speakers would explode, because that was such a great story. So yeah, I want to open it up for questions. If anybody has any questions or things that they want to say here, raise your hand. And just a small anecdote. So Cecile and I know each other here in Paris, and I texted you maybe, I don't know, 2 or 3 weeks ago asking you if you want to be part of this, and I was like somewhat reluctant. I knew you were busy. I knew like this is not the right time, but and didn't hear from you for a while, and then finally you reached out a couple of days ago, and so I was really happy that you reached out, and we're available.
Yeah, that's because the step down unit closed down, because before it was quite a rush.
Any questions from the audience?
I have a question, actually. Hi, Cecile. Really nice talk. I'm Alex Mesmej. Actually, my dad is a surgeon at APHP, actually, which is pretty funny. So I wanted to ask you a question about the next wave you are anticipating post-quarantine. So yeah, I get this because there will be lots of people outside, and another wave. Do you expect other waves? I've seen Tyler Cowen, which is like a pretty public intellectual, say that he expects 3 or 4 waves in the next year, because as soon as we don't have any vaccines, it's still going to go on and on forever. So what is your thoughts about this? Is there anything else beyond the next wave, or is the next wave the end?
So, I mean, I don't have like superpower to see in the future. I think nobody knows really what's going to happen. I mean, I think that it's we can say that yes, there is going to be a second wave, because when the confinement ends, of course, people are going to go out, and the transmission of the virus is going to keep going on. We hope that second wave is going to be smaller than the first wave, because people have been, even though they go out, we can see it already in the streets. The social distancing is pretty much respected. So we will see more patients infected, but hopefully less than the first wave. The second good thing is it was very difficult to open all those new ICU beds and get the ventilators and get the human resources. But now the hospitals are pretty organized. So hopefully if we have a second wave, the healthcare system will be able to cope with it. And so less patients will die. And then after, it's going to be a matter of how the government open or not the faucet. It's like we let people out. Oh my God, we have too many new cases of infection. So, we're going to turn it off a bit, and then on again, and then off again. So we're probably going to see more waves coming in. Hopefully every wave will be smaller, but there is so many things we don't know. I mean, in the past, we've seen some epidemic and we thought it was going to be that huge epidemic, and then boom, it disappears. Or maybe it's going to stay for, 2 years, 3 years, all the time. Like, we don't know. But what we think is probably there will be a few more waves, and probably, you know, the COVID-19 is here for at least like 6 months, a year, maybe 2 years. That's what we think. But really, how can we know? It can only be prediction, and we cannot know what's really going to happen, if that answers the question.
Yeah, thanks. Actually, I have just a very quick follow-up, which is, do you think, like, is summer going to hinder the transmission of COVID-19?
So we don't think so, because the virus has been ongoing in areas where it's hot. So we don't think that the virus is sensitive to the heat, unlike other viruses like the flu. And actually, summer is when everybody's getting out. So we're also very unsure about that. I think the best hope is to find a vaccine. I know you had a talk earlier, and I had to be on another webinar, so I'm sure you had a lot of information, but I think that's our best chance, and to find a treatment. But for that, there's still questions, you know, like, is the virus mutating so much that if we do a vaccine, you know, it's only going to be valid for 1 year, and we're going to have to change it every year, and it's going to be like the flu, it's going to be very poorly working, or is it going to be nicely working? And so far, it appears that the virus doesn't mutate too much. So if we have a vaccine, it should be pretty efficient. And how long is that vaccine going? How long is the immunity from the vaccine going to last? That also, we're not really sure. We think that it would be at least for 6 months to a year, because that's what we typically see with the immunity. Maybe it will be for much longer, but probably at least for 6 months to a year. And people are also working on treatment, but I think that if we can't get the epidemic low enough so that the virus doesn't really have anyone to, you know, enough people to infect and make an epidemic, then the best chance is the vaccines are a treatment.
Okay, thanks.
Hi there. Hi, Cecile.
Hi.
Thank you so much for sharing all of that. Yeah, I mean, it's amazing the work that you're doing. A question that I had was, you know, you were sharing that, you know, you've got your family, your husband and your daughter. You know, is there any care being given to healthcare workers that, you know, and especially their families? You know, I have a friend who basically, I think he has to separate from his wife because his wife works at a hospital and they have to kind of be apart during this time. Like, are there any measures like that for healthcare workers and doctors like yourself?
So I think in France, we're very lucky. There are a lot of things that are organized for healthcare professionals. Everything is facilitated for us, like, because, you know, there is no subway, I mean, or very few subway anymore, and trains, like we can have cabs if we want. We have like food at the hospital. Daycares and schools are open only for children of healthcare professionals. So I think that's, I mean, the country really put everything that they could to help us do our job. After, what happens inside the house is it's more personal to every individual. I have friends who, yes, like they live with the husband, and they, you know, they one sleeps on the couch and one sleeps in the room, and, you know, they eat with like social distancing, and then they don't touch the same things. And some others, we just share everything. I mean, I think it's really a personal choice. With my husband, we're like, well, you know, I try to protect myself the best I can, and I hope to not give it to you. And after, I don't see the rest of my family. But it's up to each one of us to decide how we do it at home. But for some people, it's very complicated. Like I said, my friend who lives with her mom, where is she going to put her mom? So the government did put a few hotels room at our disposition. So if some of us want to go live in a hotel next to the hospital, it's possible. Usually it's just for a limited amount of time, but it's possible. But after, yeah, I would just say that it's more up to our decision, the way we behave with our family.
Yeah, wow, that's really interesting. Thanks for sharing.
And of course, that's the situation here in France. It's not necessarily the same situation in the US, and I'm sure
exactly, yeah.
You know, the sort of like assistance that governments give in forms of hotels and things like that. But I mean, what's been really great to see is the tremendous, and you mentioned this in your talk, is the tremendous solidarity. You know, hotel owners have been opening their hotels for care workers, and that's been absolutely, yeah, great to see that. Very touching. Are there any other questions from the audience?
Well, there are some questions on the Q&A box.
Yeah, sure. So if any of these people would like to ask the questions, just raise your hand and I will. So we got Gary, Ben, and William.
So I see there's a question about access to PPE, oh my God, and other medical equipment at hospital and mental health. Okay, so I was just on a webinar with which was like worldwide with emergency pediatrician from all over the world in all continents, and France was not the PPE situation in France was not, and with the test was not the best. So what happened is France has exported abroad most of its industries. So when the COVID crisis hit the country, our only resource was to buy outside of the country, except, I mean, everybody was keeping, you know, their protection equipment for themselves. So we found ourselves with like not much. And every day the hospital, I mean, I was in contact with the pharmacy of the hospital, and every day it's like, we don't have any more disposable gowns. We don't have enough masks. So they ask us, I mean, every day when we come in, we have like this little pouch and we have 3 simple masks in it, and one N95, which is like FFP2 in Europe, and that's it. That's all you have for 12 or 24 hours, and that's how it is. And then after, you go walk in the street and you see people with N95 and they're walking alone in the street and they don't need it, and you're like, why does he have one and I don't? The gowns, we had to keep them, you know, for several patients. Basically, they were telling us, okay, you put the gown one time and then you go see all your COVID patients, and then after that you can remove it, and then you have to write down everything you saw with every patient, which is just not optimal. So that was quite a problem. For a long time we did not have a face shields, and it's only when the 3D maker shipped the face shield that we actually got some. The goggles, most of them were broken. So yeah, it was a bit of a fiasco, but I don't know, sometimes I don't want to look like I complain, because you also make it work. Like, sure, it's not optimal, but you know, you make it with what you have, and yeah, I think the most important was really trying to protect ourselves. When you really have a patient who's coughing loud in the room or things like that, then yeah, then we would be really careful. So that's for the PPE equipment. The other medical equipment, yeah, we were lacking pump syringe and ventilators. That also was a big mess, because France only has one constructor of ventilators, which was not able to make that many new ventilators, because it was relying on smaller companies who weren't working anymore and who needed pieces that came from China anyway and that were not available. So that was also a bit of a mess. We were lacking human resources also, and that's why a bunch of people like me just had to take on like a new job, you know, adapt yourself. So yeah, I mean, I do have to say there was the good side to it in my, so my hospital is just a pediatric hospital, and so we welcome adults. But I don't know if it's because we're pediatricians, but we really took special care of our adults, and I'm happy to say that we had no deaths, because we had all those pediatricians available. We were enough doctors to treat the patients, and we took care of them like we take care of them like babies. So that was the good side of it. Is I think we did quite, even though we had to go look for the competence and the knowledge, you know, all of the time, call our friends, you know, who are doctors with adults. I think we took the time to really take care of our patients. On the question for access to mental health counseling, a lot of stuff have been done in France. I mean, people can call free numbers. We've been having like free apps for meditation. A lot of shrinks have been available to give free consultation. So I don't know if I mean, maybe I'm not the right person to give the right answer, but I feel that access to mental health was really encouraged. So I think France has been doing a pretty good job about that.
I think William has a question he'd like to ask. I've given him access. Go ahead,
yeah.
William.
Hi, thanks, Cecile. That was a really amazing and moving story, and matches a lot of what we're hearing over here in the US. But one thing I have been hearing from some colleagues at the American Heart Association is that they're picking up some evidence of coagulopathy secondary to COVID. And I was just wondering if you are seeing, or is there a discussion about kind of an increase in these strokes kind of secondary to infection?
So there's a lot of publications on topic, and I don't want to get ahead of myself, but yes, we did. So I mean, it looks like the COVID-19 has an effect on small blood vessels, and that they increase, yes, the coagulation. And in the treatment, we recommend to give anticoagulants to most of the patient in quite high doses. In my department, we saw a lot of pulmonary emboli. I don't know if it's the same word in English. And we're seeing also probably vascular effects in children. So, but it's stuff that we're learning along the way. And before you can say that's how it is, you need to study, you need to have strong numbers, you need to have like a, the numbers need to be statistically significant. So I'm not the best expert in physiopathology, but yes, that's what we've been seeing, and the treatment is going in that direction also to prevent coagulopathy in those patients. Yes.
Thank you. It's just a nice confirmation of what we're hearing. Although I take your caution that it's just your own personal. We will wait for further controlled studies to make any definitive decision. But that's nice to hear this consistent.
And we have another question from Sarigama. Go ahead. You have the mic.
And I have this question that I heard that the infection level is sort of proportional to the exposure that people have towards this virus, in the sense that frontline workers are affected more severely as compared to people who get it through maybe contact, direct hand-to-hand contact or something like that. Is this true from your experience? And my second question is more of a confirmation, just some simple question. So one of my friends was telling me that currently she's working with COVID patients, but later on she'll be shifting to another ward, which is not dealing COVID patients. But she's worried that, of course, people who will be coming in could be infected with COVID as well. But right now there is so much lack of PPE that she cannot be expecting PPE in that ward at all. So in France, is that the same case, that they are not being provided PPE in the other wards, or how are they trying, or are they not even, like, what is the current case?
So to answer your first question is the same. I mean, I can give my personal opinion, but again, it's the numbers which are going to talk at the end of the day. What we did notice, I'll give you an example. Like, so we've had some pretty young patients that were in the ICU, like men around 50 years old and not much risk factors. And for example, there were dentists, and like dentists, they are really exposed to the people coughing and sending them droplets. So we might think that, yes, there is a correlation. We know that to be infected, it's not, you don't get infected by just touching a person or touching, like a desk, because that's somebody else with COVID touched before. Usually you get infected when you received droplets from another person who is next to you for like a few minutes. It's not just usually a few seconds. So it might be correlated with some serious forms of the disease, but we're not I mean, that might not only be it might not only be the only factors. There's probably like many more factors around it also. And I mean, I feel sorry because I feel like I'm a physician, so I should have like all the answers to your questions, and it's hard because there are so many things that we don't know, and there's already a lot of publication, but I don't know all of them, but I'm trying to answer with what I see on the field. And for the second question, yes, of course. I mean, I remember before you had like a definition of what a suspect was, and now you don't. Anyone is a suspect. Anyone can have it and have absolutely no symptoms. So of course, when you go in other department in your hospital and it's non-COVID departments, of course you can be exposed. So in France, in departments that are not typically seeing COVID patients, everybody just have a simple surgical mask. And then when you have to do a gesture which puts yourself at risk, like a throat swab or something like that, then you can go and get a face shield and goggles and a disposable gowns. Otherwise you don't. My personal opinion is what I try to do is, well, if I don't have to do any gestures that will really put myself at risk, next to the patient's face, I try to stay away. I try to not put my hands on my face. We wash our hands all the time, like all day long. And I mean, in my hospital, like, of course you have healthcare professionals that have been infected, but it's not the majority. We don't have the exact numbers yet, but we think it's 10%, maybe less, of healthcare workers who would be infected.
And we're going to open up just to one last question before we move on to the next panel. Are there any other questions? Well, I had a question. So, I think we were going back and forth on Twitter about this. Could you tell us a little bit more about all the initiatives that have just sprout out of nowhere, seemingly, around like 3D printing, building like 3D printed ventilators, or maybe not ventilators, but like parts for ventilators, the masks, the shields and everything and all that stuff. Like how do we, and this kind of relates to some of the questions we've had here in terms of, our access to materials from, from China, et cetera. Do you think that this will accelerate this kind of maker economy that so many people have been heralding for some time, saying like, okay, at some point we're going to be 3D printing all of our things kind of like locally? Do you think that this will accelerate that trend?
I hope it will, because it's showing that we can do great things at much lower costs. So I was part of an initiative in France at the beginning of the epidemic. And like what I tried with a group of people is to federate the 3D makers initiatives, because because I'm also in tech, makers were writing to me, and I saw 10 different groups working on the same, face shield, but they were working at a different pace with like different material. And I was like, well, it's too bad. They have to, the first one who gets it right, then everybody just make it and distribute it to everybody. It's people shouldn't be working on their own, separately. So I did this with a group of people, and we also had the APHP, which is like a group of all the hospitals in Paris. We had them to buy 60 3D printers, and we were able to print some of the medical equipment that we were missing at the hospital. It wasn't that simple, because something can be printed quite easily that are not medical device, but when you try to print a medical device like a syringe pump, you can't just print it and start using it, because if it doesn't work, you're going to kill the patient, So it was not that easy, but what we saw was the 3D makers could print, for example, all the PPE, the masks, the face shields, but the medical devices had to be printed by either industries who are able to validate the medical device side of the medical equipment. So there's really two sides of the story. It's not anyone can print a ventilator. If you want to print a ventilator, you need to make sure that ventilator answers to norms and is certificated, because otherwise maybe then you're gonna kill the patient who would have lived with a correct ventilator. So, but all of a sudden, I think that everybody saw that those, 3D makers could do things and could help, and for a much lower cost. So hopefully that will stay, hopefully.
Are there any other questions?
Yeah, so I saw a question.
Go ahead.
I saw the question. Do I think that the government's institution will be better prepared for the next epidemic? Has your organization, for instance, started talking about preparedness based on lessons being learned, or is it still too early? I have a problem with politics. I get disappointed all the time, but I hope that they will have learned the lessons. I think it's difficult because probably the next epidemic will be very different. I mean, what are the chances that it's a virus, that's in the air, and it might be something very different, for which we need very different medical equipment. But I do hope that they will have a plan on how to coordinate better, how to go get the experts, and really try to move fast and get the resources, and not wait. I mean, I saw what I saw happening a lot was that, it looked abstract for people. So, and everybody was like, yeah, I know it's like so difficult in Italy, but with us, it's going to be different, like it can't be as difficult with us. People always think that it's not going to fall on themselves. So I hope it will give them a good lesson. But yeah, I'll try to say I'm optimistic.
Well, thank you, Cécile. Thank you so much. I think on behalf of all the people in here, I want to just thank you for also, the work that you do and just being so courageous through this entire episode that we're all living here. And so to you and all of your colleagues working on the front lines, kudos to you guys and keep it up.
Thank you.
And we'll continue clapping at 8 p.m. every night, at least here in France we'll do. Thanks.